Thank you all for inviting me to chat today. The title of this presentation is Patient-Provider Communication, Bridging the Gaps Between Scientific and Popular Knowledge. And I come to the contents of this presentation by way of my background in qualitative research and social services. I'm a former child protection worker for the state of Montana and a former director of the Domestic Violence and Sexual Assault Program in southeastern Idaho. For 23 years, I've been conducting qualitative interviews and listening to people, helping them in clinical settings or their home settings or social settings, helping them develop their own sense of consciousness about issues that are important to them in relation to their health. And I might not say many new things today because we only have a little bit of time, but hopefully I'll be saying them maybe in a little bit of a different way that will allow some time for reflection on these issues and topics. So I hope you find a couple of helpful insights from this discussion. The learning objectives are not in any particular order. They're really kind of interconnected and one influences another. The first objective is really trying to understand the patient-provider communication dynamic through the use of storytelling in relation to medicine or healthcare. The second is to gain a better understanding of interactive knowledge translation. And that's really how we as providers and clinicians share evidence-based information in a way that can be taken up by patients. But also, it's about how we can listen to patients to translate their knowledge and perspectives into something that we can understand in our own cultural language of healthcare. And the final objective is thinking of ways to correct misinformation on individual and social levels. So these all sort of interact. To begin with, we'll start with storytelling, and I want to share one of my favorite quotes. The shortest distance between two people is a story. And eliciting a story or sharing a story is a very personal act, and it can also sometimes be a very vulnerable act. The great thing about stories is that they use more than words, of course. They rely on people's images that they have in their minds. You may see people talking with body language, and it helps them get their point across. And stories also provide a lens by which to understand how people are socially situated. And what I mean by that is if someone's telling you a story about how they came to a certain health situation, you may learn about power dynamics in their relationships and what kind of control they have or don't have over their own or others' behavior. So asking for a story helps people remember a health event also because you drop them into a moment in time, and this can help them frame what happened and make sense of it. Now, the hard thing about this, though, is that telling stories and listening to those stories takes time. And if we don't do it correctly, it can be triggering. There are a lot of good resources to help practitioners learn how to ask people for their stories, one being the Story Center out of Berkeley, California, which I'm really always excited to share that resource. And so if you want to know more about Story Center, just let me know. And asking questions, asking for people's stories begs listening. And so when we do this, we have to think of it as an active, engaging type of activity. It's important to listen for things like who did what, how it happened, and what people's particular roles are in their own story. And as for providers, this can actually foster a good deal of patience. If we just let someone's story unfold instead of rushing to maybe the physical or biological crux of a health issue, we have the ability to learn more and to sort of develop a timed relationship with the person where there's give and there's take. Also, as one learns to actively listen, it helps them gain skills in tolerating a lot of ambiguity, which is difficult when you're trying to help somebody meet a goal and accomplish something for their health. People often hold contradictory viewpoints. Like a perfect example would be like someone saying to me, and somebody has actually said this to me, I know my sugar is not my friend right now. I shouldn't be eating sugar, but eating sugar is the thing that my friends do together. Sugar's not my friend, but my friends like sugar. So also, if we actively listen, it can help us appreciate medical metaphor. And for example, a type of metaphor that I have heard frequently over the last 3 or 4 years, and maybe you have too, is COVID is a governmental conspiracy. And knowing this type of information helps us understand people's perspective, allow them to share their truth, and it can help us craft messages to respond to that truth. So in relation to listening, it's really about how we do it as much as it is about that we are doing it. And if there's a phrase in motivational interviewing called rolling with resistance, and that just basically means not arguing or fighting a particular viewpoint. It involves using more reflective statements like, I heard you say this, or active engaged listening, continually using your body language to acknowledge what somebody has said, and using questions that help people discover their own motivations for change instead of focusing so heavily on maybe the provider's agenda for health and change. So now that I've just touched a little bit on eliciting stories, I'd like to turn to the practicalities of patient-provider communication. And that brings me to an excellent article I recently read by Drossman and Ruddy. And they say that in order to communicate well, you have to have trust. And that's a tall order when you have limited amount of time. Current requirements of the healthcare system put pressure on the amount of time that can be given, regardless of the type of provider you are. And our interactions are timed in minutes. As a matter of fact, these authors point out that between the late 70s and 2019, provider time with patients was reduced from 45 minutes to 12 minutes. And I'm sure you've heard this before, but this whole dynamic leaves less time for patients to provide the context about their illness or their issue, and less time for them to tell a story. These authors also say that the technological demands that providers are faced with now reduce the amount of face-to-face interaction that we get with patients. Like the use of electronic medical records removes the ability to use eye contact when it's appropriate and when it's important. And asking also that, like the asking of questions by multiple people in one particular setting can build walls and not bridges. Right. So if we think about, for example, an intake process where you may have more than one person ask about what kind of medication someone is on, that takes time away from that storytelling ability. It may be a necessary function, but it is a challenge that we have to look at when we're looking at how to effectively communicate. And heaven knows that the requirements on providers for documentation have only increased. This actually creates a tension and stress for not just the patient, but of course for the provider. And, you know, these authors talk really eloquently about how this type of tension and stress leads to burnout for providers and makes it less easy for them to communicate because they're tired. So taking care of oneself is just as important in this communication dynamic. And in my mind, this is really where the art of medicine has the capacities to step in. If you can create a space and time for better communication or make the most of communication in all its forms, you'll have a better chance of getting at that story. And communication is done in ways we might not even be thinking about when we're thinking about that interaction. I mentioned that storytelling involves using body language too. It could also be the story that you're telling. How a provider touches a patient may elicit a particular response. It may elicit an emotional response. And even standing beside someone while they walk may increase the level of trust that is developed. And all these things, if they're done in the right circumstance, when appropriate, have been shown to improve patient satisfaction. On this slide, this was a 2017 study by Singletary, Patel, and Heslin. And they asked patients one simple question when they visited a clinical institution. Please describe your provider in today's visit in 2 words. And as you can see on this slide, it is unfortunate that the most of the words were on the negative side and not the positive side. But we know that providers, even though they may be hurried and rushed, also care, are also compassionate and extremely knowledgeable. So how do we build bridges with patients to give them the confidence in us to say, I trust you and the evidence-based information you're about to share with me. And so building on that concept of the roll with resistance approach, there are proactive things that we can do. Again, I've already mentioned addressing the agenda of the patient, which really means taking the time to get to understand what that agenda is and what their own personal motivations are for changing, or doing something different, or engaging in a new behavior. What can we tap into that's personal, that will make that evidence-based information make sense to them? Providing empathy and validation about beliefs and concerns really can open the door for more receptivity to evidence-based information. And actually, the validation itself is really the center of patient-centered communication. So using phrases that show you're validating, like that must be hard, or recognizing when somebody says they've had a hard time, responding with you suffered, something that can bring instant connection. Patient-centered communication, I just want to read this quote to you. The patient-centered communication that invites non-scientifically based discussion and acceptance of the patient's worldview can reduce stress on patients and providers. It gives providers the opportunity and space to realize that they are not responsible for the worldviews of their patients. And being able to articulate the worldviews of their patients can help patients understand that they have an interest and make them more receptive to that scientific discussion. So of course, reducing stress, a stressful environment, by engaging at that level can help patients cope with their illness or condition too. So all of the evidence-based medical recommendations that are statistically proven really don't mean a lot necessarily in the face of real-world circumstances that stop people from following through with the recommendations. And so sometimes people will say they don't want to do something, but what they really mean is I can't. There's no way for me to. And teasing that apart through storytelling can be very helpful. And so what is real about the interaction? I just want to pull in one of my own experiences with untangling the truth that a patient might have from evidence-based facts. And this example relates to my work on a 5-state research coalition as part of a program called Communivax, funded by Johns Hopkins Center for Health Security. In Idaho, our research explored the COVID-19 vaccine access and acceptability in the Hispanic population in southeastern Idaho. And while we learned a lot about the population's perspectives about vaccines, what we learned even more about the context within which they made the decisions to get or not get vaccinated. So through active listening and prompting of storytelling, we conducted 89 interviews. And we learned about the truths of the Hispanic population as well as the non-Hispanic population in the area. Especially when it came to interpreting the quote unquote evidence that was being presented to them. And so I'm just going to go through 5 of these truths that were true for some people, but not for everybody, but definitely for some. It was that providers themselves weren't always behind the decision to get a vaccine. And I think that the more we know ourselves and the more confident that we are in what's being presented, it makes it easier for the patient to accept that information too. Finding a way that you have the time to get the knowledge you need to answer the questions that need to be answered in a short amount of time. And sometimes the providers in this project, they were kind of reticent to encourage vaccines because they weren't sure themselves. There wasn't clear messaging about vaccine effectiveness coming from many institutions, and I know that's not news to anybody here. And providers received conflicting messages from their own authorities within their organizations. For some patients, there was definitely a lack of trust of institutions in general. And, that's a bigger discussion and a broader picture. And how do you relate individually, but how do you also relate systemically to a person? Um, and people did indeed get much of their information about the vaccines from social media and family and friends. While some did rely on public health leaders like the CDC, they interpreted all of their information through their social lenses. And when faced with social or familial pressures, some people who might have wanted to get a vaccine chose not to. So again, this is just evidence of how we learned about people's stories and provided a place for them to tell them, so we could address these issues, and we could give them more of the information they needed because they wanted it. They're like, I have a safe place to ask you this question. Now I can share it with my family. And it had a very positive effect on perceptions with the individuals that we spoke with. We did some follow-up focus groups, and it was nice to see the confidence level improve. So all of this discussion is to say that positive communication promotes good, interactive, two-way knowledge translation. And that kind of communication happens in many forms. And I would also think about, even the clinical environment that is that you are communicating in. Those send messages too that help people communicate. Are the walls thin? Are they sturdy and soundproof? How would that impact what a patient would tell you? Are they concerned that somebody might overhear and from their family that maybe they need to just go along and say what they know in their popular knowledge and not really take up that evidence base? And questions that are asked can either be interrogations, where we're really getting to the point of the provider's agenda, or they can be conversations where mutual learning is really at the center. And of course, the Drossman article really focused on the idea that creating a hopeful space and a hopeful environment is what they had found through their extensive review, improved communication and opportunity for learning, openness to learning. And that's the essential piece. When you have trust, you have openness. And that creates an opportunity to be mindful and thinking about the way we ask questions. So when I ask questions, and I'm sure others are familiar with this, I think about asking what or how questions in addition to more quantitative questions. So it's kind of the difference between asking like a how much of question, like how many times did this happen to you, instead of, and also in addition, asking questions like, how did that happen? Or how did you come to know this information? Or what is it that contributed to your decision? Framing information in what and how can really provide space for storytelling. Also, it creates opportunity for more comprehensive approaches to looking at the system of an organization and not lumping the sole responsibility on one provider. Frequently, these types of issues are societally driven. They're public health issues. It's about information. It's about misinformation. How do we work and build partnerships to address this so it's not just on one individual? And are there opportunities in your organization, your smaller systemic world? Like, what is in the waiting room? What type of interactive learning opportunities are available there that allow people to have hands-on approaches to things? Simply being open also to the many different social determinants of people's attitudes and opinions and beliefs also creates an opportunity to address them. So far, I touched on the individual level approaches and a little bit on systemic approaches to creating supportive environments. And I just want to talk about knowledge that's spread on social media or public platforms. There's an article by Bautista, it was written in 2021, and they conducted semi-structured interviews with RNs and MDs. And they found that people were trying to correct misinformation on social media, but it's met with a lot of challenges. Some of the tools they found helpful were that after knowledge was authenticated and they were sure of what they were saying, providers used 4 key principles, often in combination, to prepare messages that would be well received. The first is they reflected to understand why social media users posted particular health misinformation. Like, what was their motivation for doing it? Is that post really worth responding to? And what value will it bring? Then the reveal was to explicitly find facts that support the information with reputable references that will be accepted by that audience. The third is relatable, using plain, simple language. And the fourth is respect, so not shaming. And not even necessarily refuting, just simply saying what you have to say, state what you state, and just explain it without a right or a wrong. They also found that in the actual delivery of making these corrections on social media, people did it publicly and privately. And they either did it through priming, which is starting your own conversation on social media, or rebutting, which is answering somebody else's post. And both of these, when you go out there and you do that, they come with risks. And some of those risks have included threats, especially in the rebuttal. And so that's something that they really had to weigh and think, do I want to do that publicly, or am I better off working one individual at a time, or taking on instead of taking on probably a very vast amount of responses to something that you might post. So I just submitted an article for review to the International Journal of Public Health with Dr. Elizabeth Cartwright. She was the co-PI on Communivax with me. And in that article, we expand on the challenges of dealing with misinformation. And we call for more collaboration from social media organizations. There was a review by Krishnan who discussed the different strategies that the social media platforms use. And there are a lot of gaps and inconsistencies when it comes to truly stopping disinformation. So one study had higher rates of misleading content if the content was in Spanish or Italian. If it was in English, they caught it more and they did more with it. Also, Facebook is not exactly transparent about how they use various different strategies. Sometimes they'll just post a warning instead of removing content, and that leaves the content there. So when thinking about all of that, just remember you're one individual with limited time, and you can make the most of that time using storytelling, raising consciousness, and it may not happen in one day, but if people get a sense that you have continued interest over time with those 12 or 15-minute increments, that trust will start to expand. I look forward to seeing what social media platforms do in the future. So just to wrap up, some key points. Developing storytelling skills can improve communication with patients. Improved communication can lead to interactive translation of knowledge and evidence. That's two-way knowledge translation. And handling misinformation publicly comes with many considerations that really do need to be weighed carefully. And that is it.
Diana, thank you so much. That was a great presentation. I am allowing everyone who's in here to be able to unmute themselves. So feel free to unmute yourself at any time. You can also go ahead and just put any of your questions into the chat, but we'll do 5 or 10 minutes of Q&A. And Tara, I see you're ready to go.
Yeah, thank you so much. That was so helpful. It actually it's just great. I think you are articulating something that I think I've learned over time, and I like when it works. So it's nice to kind of define some of those features of when a conversation like that actually does go well. I think what comes to mind, because I know we have like a mixed group here, and I'm a family doctor, but I think one of the things I find really helpful when we talk about collaborating in a multidisciplinary way is when we actually have social workers here in my clinic, but they'll tell me like, hey, I kind of realized this is why the patient is not scheduling with that other provider. I realize this is why the patient doesn't want to get that MRI. And I think whenever there's another team member involved who maybe does have more time to hear that narrative, or maybe does have more trust than the doctor involved, it's just so nice to hear that. So maybe this is more of a plug for making sure if you're hearing narratives in your office around the medical care someone's receiving, I really want to empower everyone to reach out and let the PCP know, because I've definitely had those aha moments so many times where I'm like, oh man, I wish I had known that was why that wasn't happening. And so I think it's always helpful if everyone's involved in trying to understand the why behind what decisions are being made, or why patients do or don't want to do something we're recommending. So I think that's just really helpful.
Thank you for that comment. Yes, as a social worker, I was always involved in multidisciplinary team planning, case planning for individuals. And those individuals were also part of those plans. And the family members were integral part of the plans too. So sometimes that's appropriate, sometimes it's not, of course, but it's something to consider.
Absolutely. Yeah, thank you so much. And yeah, I think, yeah, we're not going to get any of the medicine done we want to get done if we don't have the buy-in, or the people don't have the means. That's the bottom line, is if they can't get to the appointment, then it's not going to happen. So yeah.
Thank you.
Thanks, Tara. Other questions from our audience. And again, feel free to unmute yourself or just put your question into the chat. All right. Well, Diana, do you have any last thoughts before we move on that you'd like to address?
Just that I know that this is brief, and that, everything like this takes time, and it's one more thing to think about in terms of all of the other things you have to think about. So I appreciated Dr. Whitaker's attention to focusing on team building and really valuing every member of the team. Community health workers are, I coordinated a community health worker program for 6 years in Southeast Idaho, and they can be essential members of a team and really bring back an expertise of storytelling to the table.
That's a great point. Those community health workers are just so important across all of our state, really. Diana, thank you so much. This was a really awesome presentation and very helpful information for our group. So thank you again for presenting for us.